The treatment of ALL has evolved dramatically over the last decade and a half or so. And what I was talking about at this meeting was the treatment of young adults with acute lymphoblastic leukemia. And the introduction of novel antibodies, including blinatumomab, into frontline treatment has been tested in a variety of settings now, particularly in the older adult population, and a little bit less so, although very recently in the children, the high-risk children, and in the E1910 trial in a relatively broad range of adults, not so much young adults, but more middle-aged and older adults. And in that study, clearly the addition of blinatumomab made a large difference in terms of event-free and overall survival. But that trial was not the typical trial for young adults, whereas the pediatric trial that was just presented at ASH was a very commonly used pediatric intensive regimen that we also use similarly in young adults with ALL. And there again, a very relatively short number of cycles of blinatumomab made a very large difference. Well, I don't think we're anywhere near in the young adult population getting rid of chemotherapy. The question is how best to integrate the antibodies into frontline treatment and whether or not that integration will be both successful, which we've already shown some success in both, as I just mentioned, the pediatric and an adult population. But we need to be very careful about how many cycles of immunotherapy are tested, when it's given, and whether or not, in the end, that introduction of immunotherapy will allow us to reduce the amount of chemotherapy and reduce perhaps long-term toxicities for our patients with acute lymphoblastic leukemia. My presentation here at EHA was on the AYA, adolescent and young adult population, and we have not yet devoted a study to the introduction of blinatumomab in that particular population. So we don't know yet, but clearly from the E1910 trial and from the Children's Oncology Group trial that was recently presented and published in the New England Journal of Medicine, the early introduction of blinatumomab in that study, in the latter study, made a difference regardless of MRD status. Similarly, in the E1910 study, the addition of blinatumomab made a very large difference, but it was given much later when patients were already in longer-term remissions in the 4th or 5th month of chemotherapy. So the question will be, again, when to integrate, but probably it will be effective depending on the measurement method used for minimal residual disease, regardless of MRD positivity or negativity. Five-year outcomes are rarely reported in clinical trials, and that's why we felt it was very important to report long-term outcomes, since we're anticipating the majority of our patients, even in the adult population, will be long-term survivors. And what we saw in our study that we just presented the other day is that, in fact, there are late relapses in B-ALL. This was prior to the introduction of antibodies, so we don't know whether those relapses will occur late or not. But about 25% of relapses in the young adult population without antibody treatment occurred after year 3, mostly between years 3 and 5. So after 5 years, it's pretty rare, without the introduction of antibodies even, that patients with B-ALL will relapse. The other interesting finding that we made during this investigation of long-term follow-up was that patients with T-ALL really do not have late relapses. And so if they're in remission at 5 years, their long-term survivorship is outstanding according to the data that we just analyzed. You know, the ALL paradigm is very fascinating right now because we do have a number of agents that we could test that might help us both enhance deep remission states potentially reduce toxicity if we're able to reduce treatment. I'll come back to that one last thing because I forgot to mention it a little bit earlier. But the other agents that we can think about are other targeted antibodies. There are others coming forward, new BiTEs, CD19 BiTEs. There is the CD22 antibody conjugate, inotuzumab ozogamicin, which has not yet been shown to be safe or effective in the young adult population, although that is being re-explored a little bit right now. And then for the TALL population and potentially the BALL population, the BH3 mimetics targeting the BCL2, BCLXL family members will be extraordinarily important. And potentially then, finally, the role of CAR T cells and novel antibodies for TALL, daratumumab, and then the CAR T cells for TALL, which are just in early phases of testing, and in BALL, which are already approved in relapse, whether we can integrate those into the front line and potentially really reduce the amount of treatment intensity and duration if we are able to safely administer those antibodies in the minimal residual disease setting. The final thing that I want to come back to is that from our analysis, which was something that was very interesting to me, and this is not about new agents, but the role of maintenance therapy seems to still be quite important, at least without antibody treatment, because the one thing that we found was that increased completion of maintenance therapy, probably completion of all treatment, is very important for outcome. And those patients who were in remission, even at the end of maintenance therapy, when it should have ended, but stopped their maintenance therapy early, did significantly worse than those patients who continued maintenance therapy. So that's not even chemotherapy, new agents, but just trying to better understand the impact and utility of our old agents.